So this week, we're going to get into cardiovascular and peripheral vascular disorders. The number one arterial disorder is atherosclerosis. Atherosclerosis is what causes most cardiovascular problems. What happens is you have plaque buildup on arterial walls, and over time, it's going to lead to hardening and stiffening of those arterial walls. That's what sclerosis means. Not only are the vessels going to become stiff and less elastic, the lumen, the space that blood has to pass through, is going to become narrow. So this is going to increase systemic vascular resistance. It's going to increase the workload of the heart. It's going to increase blood pressure. And it's going to lead to these problems: coronary artery disease, peripheral artery disease, carotid stenosis, which leads to risk for stroke. Plaque buildup on the arteries is also going to attract blood to clot. So fibrin in our blood is going to adhere to the plaque, forming thrombus, which are blood clots. Have the potential to form a thrombus and either occlude the blood vessel completely or break off and form an embolus that travels, gosh, what was I gonna say? Or plaque can even just build up and, like I said, occlude the blood flow completely. Either way, what it does is it increases your risk for myocardial infarction, that medical term for heart attack. And it also increases your risk for ischemic strokes. And we'll talk about stroke next week. Risk factors can be modifiable or non-modifiable. If you have some of these non-modifiable risk factors, such as genetics, place the patient at high risk already. Like I told you before, if you are diagnosed with hypertension at a younger age, if you have close immediate relatives, brother, sister, mother, father, children, who have had heart disease or hypertension early in life, or had a heart attack early in life, or sudden death related to cardiovascular disease, you need to be teaching these patients about modifying everything they can, because they are already at a high risk for cardiovascular events. Modifiable things, you already know that. It's things we can change: smoking, alcohol consumption, high blood pressure. You can change your blood pressure by taking your medications and maintaining a healthy lifestyle. Diet, exercise, these are modifiable. Treatment for atherosclerosis is going to include statins like atorvastatin, simvastatin. You learn about these in pharmacology. These drugs also can be hepatotoxic. If you think about it, the liver makes that bile. The bile emulsifies and melts down the fat. We learned that with the GI. On practice A, you had questions about who would be at risk for gallstones. And remember, the gallbladder is right there next to the liver, holding on to the bile. It's the liver's little change purse, the gallbladder. So if I'm taking atorvastatin, remember, hypercholesterol or hyperlipidemia, high cholesterol, not only does it lead to atherosclerosis, it also leads to fatty liver disease. It causes more work on the liver. It can cause cirrhosis. So there was a question: gallstones, hyperlipidemia, liver disease, all these things are interrelated. So even if I wasn't sure when I looked at that question, who would be at highest risk for cholecystitis, I would have known, okay, I know atorvastatin is for cholesterol. That has something to do with, the gallbladder. And it can, when someone's on a statin, they need their liver checked frequently. I would have been able to guess those answers. So next time when you're presented with something like that, you'll be ready. Antiplatelet medication keeps clots from forming. I'll talk about that in a minute. Let me move this Zoom thing to the top, sorry. Okay. Next. So this is just more pictures. These are the stages of atherosclerosis and what's going on. Don't get too hung up memorizing the stages of atherosclerosis, okay? As long as you have a general idea of what's happening. You see here, just like I told you last week, the heart has its own blood vessels, its own arterial supply. They get blood delivered from the aorta like the rest of the body. So these blood vessels, when they're affected by atherosclerosis, because they are much smaller arteries, just like the ones in your brain, smaller arteries are going to be at higher risk for occluding, right? So our big old femoral artery is probably, even though it will be affected by atherosclerosis, it's likely not going to have an infarct or have complete occlusion right in your femoral artery because it's a much bigger artery. But these smaller arteries, like in your heart and in your brain, it's going to be much easier for that plaque to build up and eventually occlude the artery, leading to myocardial infarction. Here is just a picture of what I've been describing to you, what's going on inside that blood vessel. The plaque builds up, blood tends to clot around the plaque, and then eventually we lose blood flow to certain areas of the heart. Angina pectoris is the medical term for cardiac chest pain. It is usually described as substernal, under the sternum, mid-sternal. It could be on the left side. It could radiate to the left arm. It can be brought on either by exertion, exercise, or it could be brought on by anxiety, emotional stress. It becomes unstable and alarming when it's not relieved by rest or medications. So some people live with angina. They live at home. They keep nitroglycerin on hand. They're able to take it, and it works just fine for them. For elderly people, they may not experience chest pain the way younger adults may feel it. They may not have, their symptoms may be a little more subtle, such as weakness, confusion. They may not necessarily present in the same way when they're having a cardiovascular event. That comes from slow transmission of pain. They're already on medications. They are older, their nerves are older, a bunch of different things. So not everybody is going to present with that left chest pain radiating to the left arm. You have stable angina that occurs with usually exertion or emotional distress. It can come on, it's predictable, basically. It is predictable. It lasts less than 15 minutes and it goes away when a person takes some rest. When I rest and relax, or when I take my nitroglycerin, the pain goes away. However, unstable angina, this falls under the blanket of acute coronary syndrome. Unstable angina can occur even at rest. Even at rest, sitting, watching TV, or not even watching TV, sitting, meditating, and all of a sudden I get this chest pain. That's unstable. It came out of nowhere and it's lasting longer than 15 minutes. I've taken one nitroglycerin and I still have chest pain. Call 911. This is unstable. You can continue to take the medication, but if that medicine doesn't go away with that first dose of nitroglycerin, this is probably unstable angina. If this is, again, cardiac related chest pain. People do get chest pain with GERD and other instances, but we're talking cardiac chest pain. Variant angina is more due to a spasm in the blood vessel, the coronary artery, and it can occur at rest, and it may not have anything to do with atherosclerosis. Variant angina is also called Prince-Mall's angina. So risk factors you can read here. I'm pretty sure all of us are aware of the risk factors for heart disease, obesity, family genetics, smoking, drug use, yada, yada, yada. Acute coronary syndrome, like I mentioned before, it's a blanket term. It's used to describe either unstable angina or myocardial infarction. Either way, what's going on here is we have reduced blood flow to the heart. So if a patient experiencing unstable angina comes to the ER and they we do an EKG, we don't see a STEMI or anything, a ST elevation MI. We draw troponin, we realize they're not having a heart attack. We're still probably going to admit this patient based off risk factors because what could be occurring is this could be coming in the future, a myocardial infarction. So patients with unstable angina, we still need to take this very seriously. Myocardial infarction, MI, this is when that blood flow is completely occluded and now necrosis or cellular death occurs in the heart. The muscular cells of the heart need oxygen to survive, just like every other part of the body. And the oxygen is carried by our red blood cells. So with no blood flow, no perfusion occurs and tissues die. Signs and symptoms, impending doom. You need to take it very seriously when you have a patient who's telling you, I feel like I'm dying. I feel like I'm dying. Severe sudden onset of anxiety. Now, there's a difference between sometimes panic attack makes a person feel the exact same way. And it makes someone feel like they're having a heart attack. Those still should be taken seriously because it could actually be them having a heart attack. Chest pain, like I said, is going to be under the sternum, may radiate to the left arm. It may radiate to the jaw. Last semester, we had a woman in clinical who was admitted to the hospital. She had a non-STEMI. There was no ST elevation on her EKG. And her only symptom was severe jaw pain, especially in patients she was an older woman. Older people or patients with diabetes already have, for older people, it's just wear and tear, but for diabetes, they already have nerve damage. They have damage to the blood vessels already, so they may experience pain a little differently. Nausea, dizziness, shortness of breath, epigastric pain. These GI symptoms are especially more common in women. And then at the bottom here, I'm trying to get this. I hope you guys can see the whole screen. At the bottom, diaphoresis, cool, clammy skin. This is a sign of shock. When a patient has cool, clammy skin and is diaphoretic, dripping in sweat, they are likely going into what's called cardiogenic shock. Shock will be covered more heavily in nursing 3, but it's good that you definitely know how to recognize urgency. All right, again, this I got straight out of your book, this stable angina. Stable angina, is basically predictable, comes on with stress or exercise. It can be relieved with nitroglycerin, usually lasts less than 15 minutes, and it does not have those other symptoms. And then MI, we just discussed. ST elevation MI, if you see this on an EKG, when we talk about like the severity of an MI, it's really just about which blood vessel is occluded. You don't need to, again, stress yourself out trying to remember every coronary artery. You don't need to know that to become an RN. You don't need to know that. Some of these things take time and constant learning to remember. All you really need to know is that you are taking care of human beings, and you need to know how to recognize urgency, recognize they are in danger, and you also need to know how to promote health and to prevent these events from happening. You don't need to know how to perform a mechanical valve replacement. What you do need to know is that those patients need to be on anticoagulants, and you need to monitor them for risk for bleeding, or educate them on diet or signs of and symptoms of things. Don't spend all your time obsessing over how to read EKGs, how to perform surgeries you're never going to perform. Focus all your energy into patient education and patient assessment, and knowing what to look out for. That is what your job is as a nurse, and that is what you're expected to know to pass NCLEX. So ST elevation MI is by far the most acute MI. So when you see ST elevation, these are your patients who are going to be going straight to cath lab. When a patient comes in, or when you're working on the floor and a patient is complaining of, patient is complaining of chest pain, cardiac chest pain. If your patient, especially like say the patient's already being admitted for something related to chest pain, and all of a sudden that chest pain suddenly gets worse. Or if your patient, if you're working in the emergency room, hold on. If you're working in the emergency room, and a patient comes in, you need to get an EKG. After, of course, first and foremost, assess the person, but then you need to get an EKG within 10 minutes. You need to assess the patient immediately. You need to get an EKG within 10 minutes. So don't get tripped up on that. You're always going to treat the person first. EKG within 10 minutes. You're going to continue to monitor vital signs frequently, every 5 to 15 minutes until stable. You're going to do continuous cardiac monitoring, continuous hemodynamic monitoring even, and that will be like your arterial line, or central venous pressure, that we talked about last week. That's hemodynamic monitoring. They need an IV, they probably need 2 IVs, and you're going to prepare for them to go to the cath lab. Cath lab is where they perform percutaneous coronary intervention. We'll talk about that in a second. Or if it's really bad, a patient may end up getting a cabbage, but they probably still are going to determine that after they go to the cath lab. Patients go to the cath lab. It's supposed to be door to balloon in 90 minutes. Door to balloon in 90 minutes. I'll talk to you about the balloon in a minute. But prepare everything. When a patient is having an acute MI, everything is happening very quickly. EKG in 10 minutes. Monitor, monitor, monitor. If it's the middle of the night, we're calling the cath lab team. Like that's what Chris Sheffield does. Well, he's the director now, but at some point he was probably getting called out of his sleep. When you're on teams like that, you're expected to live within 30 minutes of the hospital. You need to be here. Why? Because we need to have intervened within 90 minutes. Otherwise, this patient could lose complete cardiac function, go into cardiac failure or heart failure, or die. The acronym for treat, or mnemonic, whatever, for treating MI is MONA, morphine, oxygen, nitroglycerin, aspirin. Morphine, not only does it treat pain, it decreases the oxygen demands of the heart. So we're not just giving it to treat their pain. We are giving it because of the fact that it does relax, allow the heart muscle to relax and decrease the amount. We already have decreased blood flow, so we need to decrease the oxygen demands of the heart while we don't even have enough blood flow. Also, we're going to administer oxygen for the obvious. Keep remembering this term, perfusion. Perfusion is the delivery of oxygen to the tissues. That's what our blood does. The circulatory system carries the blood carries the oxygen. The oxygen is what makes every organ, every tissue in our body function. Our cells cannot survive without oxygen. When we go without oxygen, we go into what's called an anaerobic state, anaerobic metabolism. When that occurs, lactic acid is released. When lactic acid is released, we feel that burn sensation in the muscles, right? That's what causes the chest pain, the lactic acid release, because the heart muscle is not receiving oxygen, it's not being perfused, it is going into anaerobic metabolism. It is trying to still function with no air. When that occurs, lactic acid is released. This is what occurs in sepsis and shock, a septic shock, sorry. Nitroglycerin opens the blood vessels. I'll talk about that more in a second. And aspirin obviously stops those platelets from aggregating. You learned about that in pharm. Stops the clot formation. What's going on here? Change. All right. Those meds, nitroglycerin. Nitroglycerin is a vasodilator. Vasodilator. Let me hold up, even though I look ugly right now, don't judge. I want to show you. You're gonna look at me right now. Okay. If the blood vessel is occluded, right? It's occluded with all this plaque. Here's my blood vessel. What nitroglycerin is going to do, it's going to vasodilate. So even though that same plaque is still here, the idea is that it's going to open up the blood vessel to allow some blood to flow past. It's not getting rid of the plaque. Remember, that plaque is adhered to my blood vessel, but vasodilation is going to allow more fluid to flow through. Okay, everybody get that? I'll turn this camera off. All right. All right. So, it also, because of that vasodilation, allows the blood vessels to relax. It's going to prevent coronary spasm. Afterload and preload. Preload is the degree that the heart has to stretch while filling. Afterload is the force that is required for the ventricles to pump out. Okay, it's the force they have to pump against, like systemic vascular resistance, right? And because of all this, because it's relaxing the heart, it is decreasing the need for oxygen. Okay. Nitroglycerin, because of that vasodilation, it's going to drop the blood pressure, right? You can't give nitro to everyone. So you need to assess blood pressure prior to. If your patient is getting IV nitro, like in the instance of congestive heart failure, which we'll talk about in a minute, then you need to be monitoring their vitals every 5 to 15 minutes, okay? Because they can go severely hypotensive. If the patient is having an MI and they're already hypotensive, we cannot give nitroglycerin. It will kill them. You can't bottom out their blood pressure. Because of the vasodilation, it's going to cause headache. Headache should be treated with Tylenol. It is not a reason to stop nitroglycerin in most cases. It's a side effect. Only if the patient were stable or whatever, then would a doctor even say stop nitro. It's just a side effect. Just know, give them some Tylenol or whatever. No NSAIDs if they're on a blood thinner though, right? Morphine. Um, Morphine, like I said, is going to decrease oxygen demand. Metoprolol is your beta blocker. Beta 1 adrenergics receptors in the heart increase contractility, right? So what does metoprolol do? It blocks that action. So it decreases contractility, decreases the heart rate, contractility, decreases contractility. So it's decreasing afterload. And it's also decreasing the oxygen demand of the heart because the heart is beating slowly. It doesn't require as much oxygen as when it's trying to beat quickly. It's like walking versus running, right? So because it drops the heart rate, you already know, check the heart rate, do not give if less than 60. You want to try to avoid beta blockers in people who require beta 1 adrenergics, like albuterol, right? Albuterol is the opposite of a beta blocker. So beta blockers could counteract the albuterol action. Beta blockers can cause asthmatics to have bronchospasms. And you're going to want to monitor for low heart rate and, of course, hypotension. Beta blockers do cause orthostatic hypotension. Let's see. All right. Other medications, aspirin. Aspirin is an antiplatelet aggregate. It stops those platelets from clumping together, forming clots. It also prevents vasoconstriction. Clopidogrel, also known as Plavix, it inhibits platelet aggregation. This medication is given to those who already have atherosclerosis, those who have already had a stroke or a heart attack, or those who have peripheral artery disease, which we'll talk about later. Peripheral artery disease is basically what I just described going on in the heart, just going on in the legs. The goal is, when you guys go to clinical, if you are not able to do anything with the patients, if you can't touch them or anything, the least you could do is sit and look at their chart. Get online, get on the computer, get on Epic, look at their lab values, become familiar with these labs and what they mean. Look at your patient. What's their diagnosis? If they are a liver patient, what's their ALT? What's their AST? What is their, if they're there for infection, what's their white blood count? Do they have a shift? And look at their medication list. Over time, you should be able to know a person's medical history just by looking at their med list, okay? Clopidogrel, Plavix would alert me that this person already has had a stroke or heart attack in the past, or they have peripheral artery disease. Someone on aspirin, 81 milligrams is recommended for most adults over the age of 50. So I wouldn't be able to necessarily guess in regards to aspirin if they're taking baby aspirin. If they're taking a 325 aspirin, I may wonder, do they have some sort of issue with clots or a heart attack or something? Heparin, we give that in the hospital. That prevents thrombus formation. It is not a clot buster. It just prevents clots from growing or forming. These drugs here, they prevent binding of fibrinogen to platelets. I wouldn't get too hung up on these drugs, but if you see them, if you see this term, that's what they do. Alteplase, Retaplase, these are your thrombolytic agents. These are your clot busters. We will talk more in depth about these drugs next week with neuro. Clot busters are serious drugs. They're going to put you at serious risk for bleeding. They are contraindicated in patients with high blood pressure because you could seriously risk patients having a hemorrhagic stroke. We'll talk about it more next week, though. Anticoagulants, warfarin, Eliquis. These drugs are used to treat and prevent clots. People with mechanical valve replacements, like my dad, who has an aortic valve replacement, will need to be on Coumadin or some form of anticoagulation for the rest of their life. That is a lifelong commitment when you have a mechanical valve replacement. Atrial fibrillation, those patients are usually on anticoagulants as well. We'll talk about that in a second. ACE inhibitors. If you remember, the renin, angiotensin, aldosterone system, RAAS. This is that system in the kidneys. We talked about it. It reacts when the kidneys sense a low blood pressure or low volume. When the kidneys sense that, they are going to release enzymes, which are going to convert to different things. First, they release renin, then they release it, then it turns into angiotensin, yada, yada. It goes to the lungs, to where the lungs turn angiotensin 1 into angiotensin 2. That's where the ACE inhibitors come into play. They stop the angiotensin 1 into angiotensin 2. What angiotensin 2 does is it causes vasoconstriction. ACE inhibitors stop that vasoconstriction. They cause vasodilation, resulting in lower blood pressures. The thing about ACE inhibitors, and think about it, that conversion is happening in the lungs. ACE inhibitors also do something, they act with bradykinin, which is one of those histamines. Because of that, it can cause angioedema. ACE inhibitors can cause angioedema, sudden onset swelling of the tongue and lips, which can occlude the airway. So you need to know, the reason I'm going back over these, you need to know your farm. These drugs you need to know. These three here, the top three here, you need to know your beta blockers, you need to know nitro. Those are drugs you need to know. You do not need to know every single drug on the market, but there are certain drugs you need to know. Just like there are certain labs you do need to know the actual values, and there's some, don't worry about them as far as getting prepared for your NCLEX. You will see labs, the lab will read the labs anyway. So, but there's some that you do need to know actual values. So ARBs, if a patient does get angioedema from taking ACE inhibitors, they'll switch to ARBs because the ARBs work back down in the kidneys to stop the action of the angiotensin 2, thus causing vasodilation, stopping the vasoconstriction. Calcium channel blocking agents, they block the movement of calcium into the myocardial cells, thus relaxing the muscles and causing vasodilation. And then milrinone, this is also a vasodilator. It's only given IV in the event of severe fluid, like acute heart failure. You don't need to worry about that as much as these top three meds. So PCI, that percutaneous coronary intervention, these are the things that they could be getting done. They're still going to that cath lab like we talked about last week, but now they're going to get an intervention while they're in there. So they're still going in the same way in the groin, but they're having an intervention occur. Atherectomy is like a roto-rooter of the artery. They're going in with this catheter that has a little drill inside it. They are drilling out the artery. At the same time, it is a suction catheter, so it's sucking out the plaque too. but they're drilling away and making a way for blood to flow, okay? That's usually planned. That's usually something for someone who's already known to have coronary artery disease. This is not the thing they're doing in the event of an MI. This is what's used to treat coronary artery disease. It can also treat other artery blockages in the body. Angioplasty. So angiogram is the taking of the pictures. Angioplasty is this balloon. They go in with this catheter and they inflate the balloon, pushing the plaque up against the walls. Of course, this isn't nearly as effective as going in with the balloon and a stent. So with this one, they do the same thing. They go in with the balloon and pull it out. But when they go in with the balloon, they leave a mesh cage inside to hold the blood vessel open. Again, those people definitely need Plavix to prevent blood from clotting around their stent. I had to circle back to this whole silver fox here because remember, these patients are getting this procedure done in the cath lab. So you're still going to be monitoring that site and everything else when patients get percutaneous coronary interventions. Monitor the site for hematoma, yada, yada, yada. They are still at risk for this complication right here, cardiac tamponade. Cardiac tamponade. When a patient is getting coronary intervention, PCI, sorry, I gotta heat up my coffee. It is gonna put them at risk for this cardiac tamponade. Remember with thoracentesis, they could accidentally puncture the lung and air could come out. Well, with this procedure, with a cardiac catheterization, they could accidentally puncture the heart, but instead of air coming out, blood is coming out. That blood you see here is going to it's going to fill in the pericardial sac, and it's going to impede on the heart's ability to pump. If this is all blood, how can the heart effectively pump and deliver blood here? So all you need to know about cardiac tamponade is Beck's triad. Beck's triad. You see this cartoon guy here? He sounds like he's stuck in water. Okay, that's what you're going to hear. Muffled heart tones. Muffled heart tones. With that fluid collection around the heart and the heart's inability to pump, you're going to have severe hypotension. But blood is going to back up. So you're also going to have large distended neck veins. Beck's triad. It is distended neck veins, muffled heart tones, and hypotension. This is cardiac tamponade. What treats cardiac tamponade is this right here. It's called pericardial centesis. So remember, paracentesis in the belly is removing fluid for those with ascites. Thoracentesis in the lung is removing air or fluid trapped around the lung, again done with the needle. Pericardiocentesis is removing blood, fluid around the heart, and it can be done with a needle. If this pericardial, what they call this is just like you have pleural effusion, that's pericardial effusion. So effusion means fluid, remember? With this pericardial effusion, if it's caused by something like lung cancer or remember cancer produces transcellular fluids. Those cancer cells are releasing fluid. That can cause recurrence of pericardial effusions. What they do for those people is they actually cut a square out of the pericardial sac. It's called a pericardial window. But all you need to know is cardiac tamponade, Beck's triad, and this is what a pericardiocentesis is. All of this is a potential serious complication of a cardiac catheterization. All right. Outside of cardiac cath and PCI, the percutaneous interventions, if those don't work, the patient may need a CABG, coronary artery bypass graft, okay, CABG. CABG is what people just refer to layman's term bypass. Oh, I had a bypass, okay? What's happening is they're taking a blood vessel from the leg and they're creating a bypass. Here's the blockage. Blood can no longer flow through. Again, this can be planned with people who do already have known coronary artery disease. It can be planned, or it can be the result of a serious myocardial infarction. Either way, they take those blood vessels and they just create a new pathway. Don't waste your time reading. I read your guys' books and they give you way too many details about intra-procedure stuff. You are not coming out of school in RN expected to go be performing cardiothoracic surgeries. That's not what you're doing. You're the nurse on the floor. You're going to be preparing the patient to go to surgery, and you're going to be receiving them much later after the surgery. ICU is where this patient is going to go. They're going to be on a ventilator. So coming straight out of school, you're not going to take care of a patient immediately following a CABG. So that is not something you need to be expected to know. Basic nursing care of a patient, first of all, just being familiar with what the CABG is. When people say, oh, I had a triple bypass or quadruple bypass, that just means how many areas they had to bypass, okay? How many of these connections they had to make, these detours. So for me on the floor, all I need to know is my patient needs to be NPO. I need to check their vital signs and their blood glucose. I need to prep them so that they don't get MRSA. And basically that's with every surgery, a chlorhexidine gluconate bath. That's what's going to prevent MRSA. For surgery, you're going to hold anticoagulants, right? And you're going to make sure your bleeding times are good so they don't bleed out. And then baseline, like I said, vital signs, EKG, chest x-ray, and everyone gets a blood glucose. Post-operatively, ABCs, same stuff, different surgery, same stuff. ABCs, monitor airway. These patients are going to be in an ICU, intubated for some time, but when they're extubated, airway. If they had an ET tube, monitor, make sure it didn't slip into the right main bronchus. Make sure their SpO2 is good. Tell the patient they need to splint their incision, cough, deep breathe, use incentive spirometry every hour. These patients, surgery in the abdomen, surgery in the chest, they're going to be at risk for atelectasis and pneumonia. So we're going to teach them all about coughing and deep breathing. If you've ever seen a patient, most heart floors, they give them a heart pillow just for this purpose. They give them a little cute heart-shaped pillow, little trophy showing they had open heart surgery, yada, yada. They're going to have chest tubes. They just had open chest surgery. They're going to need chest tubes to drain that excess blood and fluid in the chest naturally after the surgery. There was a question on, I think, practice A about chest tube, and it had a copious amount or blood in the chest tube with clots. That's normal after chest surgery. You're going to give pain meds, monitor for any infection or other abnormalities. When they do the surgery, I'm just showing you, this is external, this is the heart pump. This is a machine they call the heart pump. It is taking the work of the heart right now, while they do the surgery. They have to paralyze the muscle. Some people who are in serious cardiogenic shock after an MI may even be temporarily put on the heart pump after surgery. All right. Dysrhythmias. Dysrhythmias are basically just disorders of formation or conduction of the electrical impulse in the heart. Again, you don't need to really obsess over how to read an EKG in detail. You do need to know what is the P wave, what's the QRS, what's the T wave. You do need to know, probably the timing of the PR interval and the QT interval. Those two, you do need to know timing because those could come up on, those are the things you need to know as an RN. There are 5 dysrhythmias basically you need to be aware of. You need to be knowing how to look at a EKG and knowing its normal sinus rhythm. The ones I showed you in last week's lecture. Hold on, let me take a sip of coffee, please, Lord. Okay, so because the electrical conduction is disturbed, it's gonna cause disruption in the rate, the rhythm, or both, right? It can cause no symptoms, or it can completely alter the blood flow and cause hemodynamic changes like hypotension. It can cause severe bradycardia, different things. It's going to be diagnosed by looking at an electrocardiography. So just remember your P wave, your PR interval, your QRS, ST segment, because this is where we're going to see that elevation, right? And the T wave. U wave is usually only visible with what electrolyte imbalance? U wave.
Hypokalemia.
Hypokalemia, yes. And what happens to the T waves in hyperkalemia? What happened to the T wave? Hyperkalemia.
It's flat.
No, tall and
Peak.
peak.
Peak,
Tall
yeah.
peak T wave. Hyperkalemia, hyper T. Hypokalemia is a U wave, right? Tall peak T waves with hyperkalemia, U wave and T wave depression with hypokalemia. So remember that one, okay? All right, so when we look at this EKG, come on, change. All right, when we look at this EKG, this is what we're seeing. Remember, depolarization means the contraction, right? Systole. Atrial depolarization, that contraction of the top half of the heart is what our P wave is. Septal depolarization, so this is that impulse is now passing down the septum. That's your Q wave. Then we get to the R, which is the beginning of contraction of the ventricles. The S is the ending as that impulse travels up the ventricles. And then as the ventricles relax and stretch, we will see a little T wave repolarization. So these are the different, what's going on when you look at an EKG. It is following this electrical impulse. So that's what you need to know. Because if you knew this, right, if I knew P wave is atrial defibrillation, then I'm going to know all my atrial dysrhythmias have to deal with my P wave, right? So atrial flutter and atrial fibrillation are your 2 major atrial dysrhythmias. Atrial flutter is in a sawtooth appearance like this. These are your P waves. You can tell what's the P wave, what's the T wave. What's happening in a fib and a flutter, oops, sorry. Oh, where's my movie? How in the world? Oh, I know, it's on the next screen. Okay. What's happening in AFib and a flutter is the atria are not giving out that SA node is not kicking out the signal it's supposed to. So the atria are quivering. So if you really looked, if you took a piece of paper and marked the distance between R to R, this top peak, you would see this is an irregular rhythm, right? The rhythm is irregular because these QRS complexes are spaced out all different, right? So you have this sawtooth appearance with this irregular rhythm. This is atrial flutter. Flutter is the sawtooth. AFib is that quivering. AFib, the line just looks like this. There is no P wave. It's some weird quivering. And again, it's irregular. The QRS complexes are irregular. Now, don't get obsessed with looking at, oh, it's upside down. When you're doing a 12-lead EKG, remember some of the leads are down on the legs, some are under the heart, some are above the heart. So depending on what lead it's in, some waves will be upright, some waves will be upside down. But you can see here, this is AFib, okay? On your ventricular dysrhythmias, these are the ones that really tend to lead to cardiac arrest. Although any dysrhythmia, I mean, could become potentially fatal. AFib, because of that, and a flutter, because of this irregular response of the ventricles, it can lead to severe tachycardia. It would be called AFib with a rapid ventricular rapid ventricular response. AFib with RVR. That's what that means. So you would have AFib and their heart rate's like 160. There's also a condition called SVT, supraventricular tachycardia. And I'll talk about that in a second. Okay, ventricular though, dysrhythmias. Now, you could have a PVC. This is this here, just some weird random heartbeat. Like, oh, my heart skipped a beat. Happens to everybody. A PVC here and there is nothing to be alarmed about. However, if you start to have frequent PVCs, if it starts looking like this, now you're in VTAC. Frequent PVCs is usually a sign that patient is about to code or something. Some significant cardiac event is about to occur. So even though having a skip beat here and there is nothing, having it more like if you're having 6-7 PVCs a minute, you need to be alarmed about that. Ventricular tachycardia, that's this picture here. Sustained ventricular tachycardia, it can be fatal. And this is ventricular fibrillation, which is probably going to be accompanied by pulselessness. Well, not pulselessness, but an extremely weak pulse, sorry. Both of these are your shockable rhythms. These are your rhythms you're going to use your defibrillator, okay? In ACLS, and you'll talk more about that in nursing 3. This bottom rhythm, I'm pretty sure everyone's familiar with asystole. That's no heartbeat, right? No heartbeat, asystole. And AV blocks, I'm not going to even confuse you trying to talk about AV blocks. Basically, all that's happening is there is a conduction issue in the AV node, okay? But we're not going to even get into that because you really don't need to know these things to become a nurse. And I don't want you over. What's happening is I think a lot of you guys are over studying and trying to cram way too much information. So I'm trying to keep it, you know, as straight to the point as possible. Management of dysrhythmias, obviously continuous cardiac monitoring, EKGs. Telemetry is this. Telemetry is continuous cardiac monitoring, but now they can get up and walk around because they have this little box they can carry around. A Holter monitor would be like a telebox or a smaller device that a patient wears at home for about 7 days. That's when the doctor uses that. The cardiologist will send them home with a Holter monitor to diagnose the dysrhythmia. Obviously, any cardiovascular disease, cardiomyopathy, which is weakness of the muscle, any of that can cause dysrhythmias. Any prolonged shortness of breath, hypoxia can cause dysrhythmias. Heart attack can cause dysrhythmias. Drug abuse, electrical disturbances. I'm sorry, electrolyte disturbances. So I want to play for you guys this video on atrial fibrillation. It's only 2 minutes, but atrial fibrillation is the most common cardiac dysrhythmia. This is the one you will see the most. So give it a moment.
A healthy heart works continuously to pump blood around the body by beating regularly under the control of electrical impulses that originate from the sinoatrial or SA node, the heart's natural pacemaker. These impulses radiate from the top to the bottom of the heart in a coordinated way. Each heartbeat consists of 2 stages where blood enters the atria, which subsequently contract, and forces blood into the ventricles. These in turn also contract, forcing blood out of the heart into the pulmonary and systemic circulations. In atrial fibrillation, electrical impulses do not originate in the sinoatrial or SA node, but from a different part of the atrium, or in the nearby pulmonary veins. These abnormal electrical signals become rapid and disorganized, radiating through the atrial walls in an uncoordinated manner. This can cause the walls of the atria to fibrillate or quiver rapidly, rather than contracting normally. Electrical signals are transmitted irregularly from the atria to the ventricles, which both fail to contract in a synchronized way. During atrial fibrillation, because the atria do not contract regularly, blood does not empty efficiently into the ventricles and begins to pool in the atria, especially in the atrial appendages. This pooling of blood can cause clots to form, which, if dislodged, can travel in the bloodstream towards the brain. Clot, or embolus, can potentially obstruct narrow blood vessels, often the middle cerebral artery or its branches, and prevent the normal flow of blood. The reduced supply of blood and oxygen to a particular part of the brain can result in tissue death, leading to ischemic stroke.
All right. Now I'm so tired, I had to make more coffee. Okay. Where we at?
A healthy heart works continuously.
Okay, sorry about that. Okay, so with the dysrhythmias, here's just a quick, straight to the point medication list and treatment options for different dysrhythmias. If the dysrhythmia causes severe bradycardia, especially now, some people, I'm sure you learned this before, athletes, for example, tend to have a slower heart rate. There are people who live just fine with their heart rate. My brother's a personal trainer. His baseline heart rate sometimes is like 48, 46, but he works out all day, every day. Runners. So it's not just we have to look at the bigger picture, look at the patient. We don't treat numbers. We don't treat labs. We don't treat diagnoses. We treat people. So usually it's if the patient is symptomatic with the bradycardia. Yeah, see, yep, low heart rates. Yep, and even a murmur can be oh, Gallo been out here pumping that iron, he's 50. Okay. Yeah. So yeah, so I don't know, if you see a cardiologist, they will tell you like athletes tend to have a slower heart rate. They're used to, running and getting that heart rate up high. So they have that slower heart rate. So when we're treating bradycardia, the patient, it's when they become symptomatic. They're having dizziness, weakness, that kind of stuff. Medications are these. You will go into more depth with these meds next semester. So I don't want to overwhelm you with learning right now. Pacemakers are what we're going to just talk about briefly. And a pacemaker is it could be external or internal device used to take on the role of the SA node. The SA node is the internal, our natural pacemaker of the heart. And the pacemakers usually set at 60 beats per minute. Atrial fibrillation, you just learned about that. And then there's also supraventricular tachycardia. I forgot to put that in here. But that's still emergency medicine, and that's what you're talking about next semester. But basically with SVT, patient's heart rate's going to be up in the 160s, 170s, even as high as 200. With that, when the heart is pumping that fast, there is no time in between beats for the heart to fill with blood. This is why patients with tachycardia have a weak, thready pulse. This is why I said when you see a patient with sustained VTAC or VFib, even though technically the heart is still beating, you barely can feel pulses because there you might be able to feel them just in those big, large arteries because that rapid heart rate is not effectively pumping any blood. So those patients are going to have hypoxia, decreased perfusion, confusion, even pass out. That's why you get dizzy. No oxygen is getting to the brain. Um, and then these are the other meds. Like I said, these are all ACLS. You're going to talk about ACLS stuff next semester. Synchronized cardioversion and defibrillation, I'm going to talk about in a second. And then remember, AFib is usually going to require anticoagulants. I want this to go. Okay. Cardioversion. Cardioversion is done to treat atrial dysrhythmias. And basically, it is like shocking the heart. But with that one, they are trying to synchronize with the heart's rhythm. So that is to hopefully just recapture get the SA node to recapture its role as the heart pacemaker. And defibrillation is what we're doing when we're providing ACLS CPR. Okay, defibrillation is unsynchronized. It's done in an emergency, and it's used to treat VFib, pulseless VTAC. We do not shock other rhythms, just VFib and pulseless VTAC, V-tachycardia. All right, nursing considerations. When patients with AFib are getting that cardioversion, what happens is that shock, that jolt of energy can loosen up clots in the heart. That blood's been pooling, there's clots there. It can loosen up those clots. So this is not a surgery. So we want our patients to continue anticoagulants to avoid clots. And then if they're on a anti-dysrhythmic drug like digoxin, hold it 48 hours prior to. All the rest of this, I mean, you know this stuff. Yell clear. Don't shock your coworkers. All right. You may want to, but don't do it. All right. Pacemakers and internal coronary defibrillators are just what I said. You have a pacemaker. which will just keep the rate of the heart normal. It only treats rate. It does not do anything for the rhythm. The pacemaker is just setting the pace. And usually it's set at 60 beats per minute. Depends on the cardiologist. You're not a cardiologist. All you need to know is the pacemaker is setting the rate. An internal defibrillator is setting the rhythm. It will send a shock to the patient in the event of a shockable dysrhythmia. Potential complications, same as with the cardiac cath, they could get cardiac tamponade, or they could have the pacemaker slip out of place. All kinds of things can happen. You got to be careful. You don't want these patients, unless they have an MRI approved device, they should not be going into MRI. Those magnets in the MRI could potentially disengage their pacemaker, the duties that it's doing. You guys want to take a 15-minute break?
Yeah. How many slides do we have left? 29?
We're on, what are we on? Oh, let's look now. We need a break. We're on 72 and I'm going till 89.
Oh, okay.
Not bad. I'll take a break though.
We didn't
Yeah.
start at 70. We started at 40 something.
Okay.
Yeah,
Alright.
because I added this. This is part 2 of last week. So 44. So we're more, we're like 2/3 done. But I know sitting and staring at the computer with no talking is boring as hell. I know it. I put myself to sleep. So let's get up, walk around, drink your coffee. Dana, go smoke your cancer stick, take a break, and we'll get back together at 11. What's that, 11?
Thank you.
Yeah, girl, go take a break. Relieve this stress. I don't want my people out here burn out before you even get into the field, okay? This week, we're laying in bed. We're going to learn some more about the heart, answer some questions, and chill out. We're taking a break before the spring break. So 11:35, we'll get back together.
Okay.
All right. All right, so moving on to heart failure. Okay, heart failure. It's basically a term to describe the heart's inability to pump. Inability to pump effectively. So it can result from a number of things. Prolonged chronic hypertension. Hold on.
Okay, I'm just gonna go to the bathroom and I'll be back.
Hush. All right, sorry about that. Now, all right, so it's the inability of the heart to pump effectively. It could be caused by hypertension, coronary artery disease. Remember, chronic respiratory disorders like COPD is going to lead to right-sided heart failure called cor pulmonale. Whatever the case may be, what is happening is that left ventricular ejection fraction, the ejection fraction we see on the echocardiogram, is dropping significantly, and the heart is no longer doing its job, pumping the blood effectively. Because of that, it leads to congestion in the systemic vascular system. Systemic meaning the whole body, and the pulmonary vascular system. And then that's how we get all the different symptoms of heart failure. All right. Remember back from last week, the direction blood flows in the heart. If you remember which direction blood flows through the heart, then it will help you to distinguish between right and left-sided heart failure. Right-sided heart, the right heart receives blood from the superior and inferior vena cava, right? The heart is going to receive blood from the body on the right, and then it is pumped out to the lungs. That is why when the lungs start failing, blood starts backing up to the right heart, leading to right heart failure. When the right heart fails, blood starts backing up, leading to systemic vascular congestion. So these people are going to have the symptoms of edema. They're going to have hepatomegaly. They're going to have weight gain. They're going to have the signs and symptoms affecting the whole body. The left heart pumps blood out to the rest of the body. So therefore, people with hypertension, atherosclerosis, those people are gonna end up with blood going, not enough blood going this way, more blood is gonna, traffic's gonna get backed up, and then it's gonna lead to left-sided heart failure. As the left side of the heart fails, blood's gonna back up and it's gonna go to those pulmonary veins, leading to pulmonary congestion, pulmonary hypertension, pulmonary edema. They're going to have dyspnea. They're going to have shortness of breath. They're going to have orthopnea, shortness of breath when lying flat. So that is left-sided heart failure. Here's some pictures to help you understand even more. Left-sided heart failure, again, blood is backing up into the pulmonary vascular system. So those are your people with nocturnal dyspnea, orthopnea, sleeping, shortness of breath when lying flat. So they're going to be telling you things like they're sleeping with multiple pillows. They have to sleep in a chair, those kind of things. They have cough. They're going to have a productive cough, maybe pink frothy sputum, just like anybody with pulmonary edema, ARDS. And then because of that, let me go back. Because of those respiratory symptoms, they are going to end up with hypoxia and confusion. Right-sided heart failure caused by the respiratory disease usually is cor pulmonale. Cor pulmonale is going to back up fluid to the systemic side, and therefore you're going to have peripheral edema, enlargement of the spleen, enlargement of the liver, hepatomegaly, splenomegaly. You're going to have ascites. Fluid is going to go wherever it can go. They're going to have anorexia. They're probably not going to eat much because their belly and the rest of their body is full of fluid. Weight gain, distended jugular veins. These are all signs of right-sided heart failure. So when we're looking at our patients with heart failure, BNP is a chemical released as the heart tries to stretch and accommodate for all the fluid. BNP will be released. BNP is that is a blood test. It's going to let me know, like if a patient has shortness of breath, let's draw or they have shortness of breath, their chest x-ray, remember I told you before, is going to mimic pneumonia. They may have consolidation. They may have pleural effusions bilaterally. You hear crackles in the lungs and they're short of breath and they're hypoxic. The x-ray, like I said, may not tell me, is it pneumonia or is it heart failure? But if I draw a BNP, and it is elevated, usually greater than 100 or greater than 150, I know that this person is having heart failure. It's not a lung problem. It's a heart problem. Hemodynamic monitoring, I already told you about that last week. CVP, pulmonary wedge pressure, all that. That's all you need to know. Those things measure hemodynamic properties, measuring internal pressures in the heart and blood pressures in the arteries. Echocardiogram, echocardiography, because the heart is failing and because we're fluid, even though we're fluid overloaded, the amount of fluid and blood successfully ejected from the left ventricle is going to be reduced in heart failure. So normal is 55 to 70 according to ATI. Some hospitals say 55 to 60, 55 to 65, but 55 to 70, that's a decent range. And heart failure occurs once that number is below 40%. So ejection fraction is, they're gonna have low, cardiac patients with coronary heart failure are going to have reduced ejection fraction. Treatment. So we need to give them those drugs that reduce preload. They reduce the amount of stretching that the heart has to do. Because all that stretching, it's like elastic bands you work out with. You keep stretching, elastic pants. You keep wearing the same leggings every day, them bad boys are gonna get loose as a goose. Elastic is gonna wear out. So same thing with the heart muscle. Preload is the degree to which the heart has to stretch. If my heart has to keep stretching on out like that, eventually it's going to lead to what's called a dilated cardiomyopathy. My heart muscle is loose as a goose, baby. It is just loose. It is not expanding and contracting with that force it used to have. So we need meds that are going to reduce preload, reduce that stretch. Diuretics, ACE inhibitors, ARBs, calcium channel blockers. All these drugs here that I just listed on this list will reduce preload, okay? Nitroglycerin reduces preload and it also reduces afterload. Nitroglycerin is going to help blood vessels dilate to allow accommodation for all that extra fluid circulating, right? That nitroglycerin, these are your patients you'll probably see on IV nitro in a acute phase. Now, heart failure can flare up acutely or the symptoms can subside. They can go back. You can live, say, COPD. You can live with COPD and then go into an acute exacerbation. You can live with heart failure and take your meds and then have an acute, after the holidays, you've been eating holiday ham, sipping on fruity drinks and going crazy, partying with your family, and now you're in acute heart failure. Now you probably need to be admitted and diuresed. We'll give you IV potent diuretics. You may get some nitroglycerin to help reduce afterload and preload and open up the blood vessels to accommodate for all that extra fluid. If your heart is in horrible condition, well, then you're going to end up wearing a vest that is basically doing the work of your heart for you. The LVAD, the ventricular assist device. This is some high level critical care stuff. Even to work, if you were in a hospital and a patient with LVAD comes, you call the local hospital that has the LVAD team. Not every hospital is even equipped to deal with this. So do not spend your time studying this because it doesn't matter to you at this stage in your nursing career. Not saying it doesn't matter. Being familiar that people have these things is just all you need to know. Heart transplant. Same thing with any transplant. Infection, infection, infection. These people are immune compromised. We want to protect them from infection. Infection is one of the leading causes of death after a heart transplant. Supplemental oxygen, because these people are having pulmonary edema, like those in ARDS, they need not only oxygen, but they need that force a lot of the time because that lung tissue is swollen and can't expand. So with that, they're gonna get the BiPAP. Let me hide these meeting controls because they're getting on my nerves. Okay. Next is teaching. I mean, the teaching is the same with anybody with any heart issues. We're teaching them about rest. So, once a patient, we know they have heart failure, heart disease, we may not be encouraging these people to do strenuous exercise 5 days a week. These people need rest. Why? Because it decreases the oxygen demands of the heart. They can do some moderate, light aerobic exercise. We want them to exercise, but we also don't want them to overdo it. Avoid exercising in extreme temperatures, avoid dehydration, avoid electrolyte imbalances, eat a good nutritious diet. Patients with atherosclerosis, they need a diet high in fat, low in fat, Jesus, and high in fiber. Low in fat, high in fiber. That's going to help prevent plaque formation on the arteries. Low sodium diet is needed for patients with heart failure to reduce risk of fluid overload, and for my patients with hypertension. Low sodium. Lifestyle modifications are critical in teaching patients. For patients newly diagnosed with high blood pressure or diabetes, the number one treatment first is lifestyle modifications. A patient may not even get put on medication for either of those conditions initially, because with diet and lifestyle modification, a patient could reverse the type 2 diabetes and control type 2 diabetes. A patient could reverse hypertension in the early stages. As it continues, then you're going to be in trouble. Now, pediatric heart problems, right? You're not coming out of school becoming a pediatric cardiologist. So with that said, there are about 4 major pediatric disorders as far as congenital disorders: PDA, AVSD, tetralogy of Fallot, and coarctation of the aorta. Those are the 4 pediatric congenital heart defects that really all you need to know is all of them are going to lead to heart failure. Okay. PDA causes this opening in between the aorta and the pulmonary artery. Because that left ventricle is so much stronger than the right, that force of blood, into the aorta is going to force more blood to go into the pulmonary side, therefore leading to pulmonary congestion. Okay. And then with AVSD, this is going to cause hypotension, regurgitation. Blood is just flowing back and forth in between the atria and the ventricles. Okay. So, and then same with tetralogy of Fallot is going to cause 4 different defects in the heart. All of these are going to lead to heart failure. Signs and symptoms of heart failure in children is the same as adults. Orthopnea, lying flat, that was on practice A. There was a question about an infant or something with heart failure. Orthopnea is a sign and symptom of heart failure, period. It doesn't matter how old the baby is. There is also, with the tetralogy of Fallot, these babies, they were called blue babies, is one of the, because of the decreased perfusion, these babies tend to be cyanotic. And one key thing with tetralogy of Fallot, these babies will be observed squatting a lot. They tend to squat because squatting is going to increase the blood flow back up to the heart, right? When I bend at the waist and all that, that is increasing the pressure of blood flow going backwards to the heart. So you will see babies who are hypoxic, babies with heart failure squatting. Other diseases, inflammatory heart diseases, cardiovascular diseases that can affect children. Kawasaki's disease. Kawasaki's disease causes inflammation of the arteries. It can specifically affect the coronary arteries. Signs and symptoms, they're going to have this red cracked peeling skin on their hands. They're going to have red bloodshot eyes. They may have fever, red cracked lips and tongue. Remember, fever is a sign of inflammation. So any inflammation, even cholecystitis, those kind of things could still cause at least a low-grade fever. Fever accompanies inflammation. And then rash. So the red crack peeling skin especially is one of those hallmark symptoms of Kawasaki's disease. The other one affecting children a lot is rheumatic fever. Rheumatic fever is a result of that strep throat infection. They may have, just like rheumatoid arthritis, that it's an immune response to a strep A infection. So that immune response can cause polyarthralgia, pain in multiple joints. It can cause chest pain. It can cause rash on the skin. These are all the classic signs and symptoms of rheumatic fever. With this, you need to treat the strep A infection and administer NSAIDs. Finally, the last few slides is just the peripheral vascular system. Remember, in the peripheral vascular system, outside of the lungs, the arteries carry oxygen-rich blood away from the heart, and the veins carry deoxygenated blood back to the heart. So any arterial issue is going to deal with blood coming away from the heart, and any venous issue has to do with blood going back to the heart, right? So peripheral artery disease, going back just like coronary artery disease, it results from atherosclerosis, and it's going to lead to decreased blood flow away from the heart. So the main hallmark symptom of this is intermittent claudication. What does that mean? It is a numbness, a burning, cramping pain with walking exertion. It usually can go away with rest, but as peripheral artery disease worsens, these patients are eventually going to be complaining of claudication even at rest. Okay, claudication is the burning, cramping pain. Intermittent claudication is with movement. As it progresses, you may not be able to palpate pulses in their feet. You may see temperature change in the feet. The feet are cold to touch. They are not going to have edema. There is no edema. Blood is not getting down there. So there's no reason for swelling because the blood can't get down there. So the pulse is going to be weak or non-palpable. You may need to use a Doppler just to get a pulse. You're going to encourage them not to elevate the legs, Elevating the legs when they're already having trouble with blood coming away from the heart is just going to make even less blood come towards the leg, right? We elevate for swelling. We elevate for venous issues to promote blood return to the heart. In peripheral artery disease, we do not need to elevate. Pain is usually relieved by putting the leg in a dependent position, dangling, trying to get more blood to flow, letting gravity work for you. When you do have them drop the leg in a dangling position, the color you may see this here, rubra, in question A, rubra. These pictures here, A and B, is a before and after a patient had intervention. So those same interventions I showed you with coronary artery disease, whether it's an atherectomy, whether it's a balloon angioplasty or a stent, those same procedures will work for these patients, thus restoring blood flow, and then their leg doesn't look like that. The layman's term for when they have an emergency, so just like a heart attack, you could have an emergency occlusion of the vessels of the leg. This leads to necrosis. This can lead to amputation. So diabetes is not the only reason people get legs amputated. That is a misconception many people have. Smokers, people with severe atherosclerosis and peripheral artery disease are at just as high a risk for amputations if we are not able to successfully restore blood flow. Other signs and symptoms, because they don't have good circulation and perfusion, they don't have any hair on their legs. They end up with shiny skin. Their toenails look dead and thick. They have a prolonged capillary refill. They may get arterial ulcers on the toes, usually on the most distal portions of the foot, whereas venous ulcers are usually up on the ankle. Just like coronary artery disease, they can also get a graft. They can get the bypass surgery. This is the femoral artery, the popliteal artery, and then moving on down the leg. And what this is called is a fem-pop bypass. You may have heard of it before. You're going to monitor them just like you would if somebody had a coronary artery bypass. You are going to avoid elevating the legs, right? And you also do not want them to cross the legs. Crossing the legs just further obstructs the blood flow. Other peripheral diseases involve venous disorders. This is going to interfere with blood coming back to the heart. Blood is not coming back to the heart. So with VTE, there's three main disorders: VTE, venous insufficiency, and varicose veins. VTE is venous thromboembolism. Clots are forming as a result of probably venous stasis, which is blood standing still, hypercoagulability, which is thick blood or damage to the blood vessels. That is Virchow's triad, okay? These are the things that lead to that. And eventually you're going to have either embolisms of the superficial veins, which is not that serious, compared to deep venous thrombosis. We'll talk about that in a second. The other thing that can happen is venous insufficiency. This is because, remember, blood as it flows, so like here, blood flows along this big ugly vein, and all along the way there are valves. We have valves in our heart to prevent blood from flowing backwards. We have valves in our veins to prevent blood from flowing backwards. People who have long-standing jobs like cashiers, people who are on their feet a lot, or people who just have chronic hypertension can damage those valves and therefore lead to venous insufficiency or varicose veins, large dilated superficial veins. So both of these are a result of increased pressures, whether it's people who just stand a long time for like 50 years, you've been a cashier standing, or for those who have just chronic hypertension. DVT, again, Virchow's triad, like I just mentioned before, the hypercoagulability, venous stasis with the blood just pooling, sitting still, and also damage to the blood vessels themselves. Any of those things are going to could put you at risk for DVT. Some of those things include major surgery, artificial joints where your blood tends to clot around them, immobility, like prolonged car rides, prolonged airplane rides, prolonged hospitalization. You will see every hospital everywhere in the United States, when patients are admitted, they're going to get some form of VTE prophylaxis. We're trying to prevent a DVT from forming, right? So VTE prophylaxis, if my patient is young, if you're young, you just delivered a baby, there's no other medical problems, the VTE prophylaxis will just be ambulation. That patient should be up and about, walking around, promoting blood circulation in the legs. That's VTE prophylaxis. Using SCD boots, those little massager things that we put on in the hospital that inflate with air and we put them on their feet and their legs. Those are called SCD boots. We put them on after major surgeries. That is to promote blood circulation and prevent risk for DVT. Heparin, enoxaparin or Lovenox. Those are given in the hospital for VTE prophylaxis. You see people getting Lovenox injections daily, not because they have a blood clot, but because they don't walk, so I can't do ambulation, and they are at significant risk for a blood clot. So we will give them low dose heparin or Lovenox. That's what it means when you go to clinical and you see VTE prophylaxis. It's something that will be ordered on every admission for every single patient. Assessment, calf pain. Now, we used to tell patients to plantar flex the foot to elicit the Homan sign. Now we don't do that. Why plantar flex? Meaning like pump on the gas. If we're advising a patient we know probably has a clot to plantar flex, they could essentially dislodge the clot. However, if a patient is telling you they have calf pain, that would be a positive Homan sign. They get calf pain with walking or flexion of the foot, but we are no longer going to ask them to perform that test. They're going to have that redness, edema, erythema, like you see in the picture. They're going to have edema, swelling, and they're going to have redness. People with PAD are going to have rubra, redness, but no swelling, right? People with DVT are going to have redness, swelling, and hot to touch. People with cellulitis are going to have redness, swelling, and hot to touch, but it will likely be accompanied with other signs of infection. So a lot of times patients who come in with cellulitis, they still get an ultrasound to rule out DVT and vice versa. So as a nurse, these are the things you need to know. Signs and symptoms, what to look out for in my human being patient. You don't need to become obsessed with learning all this patho and cellular and all these things. Like, unless you just want to be that nurse that sits at the nurse's station and brags to the doctor about all this nonsense they know and still have no clue how to take care of humans, that's fine. But our job as nurses, we treat human beings. So knowing your signs and symptoms, your assessment, knowing risk factors, because these are the people you're going to watch, and these are the people you want to teach the most, right? Major complications of any disorder, any procedure, those are things you want to know as a nurse. So again, assessment, the pulses are probably not palpable. D-dimer is a blood test, and it measures the amount of fibrin degradation products. That means my body is releasing chemicals to break down clots. D-dimer is a chemical my body is releasing to break down clots. And when there is excessive D-dimer in the body, then we know that person likely has some clot formation somewhere. But it is not the end all be all to determine blood clot. For the legs, we're going to use ultrasound, and for the lungs, we use CAT scan with dye or a VQ scan in nuclear medicine. Major complication is going to be an embolus formation. Embolus is when a thrombus is the clot in the vein. Embolus is when it breaks off and travels. An embolus travels, a thrombus does not, okay? Thrombus is the clot just sitting there, like, oh, I have a thrombus in the leg, then that's where that clot is, versus an embolus traveled from elsewhere, okay? Pulmonary embolism, usually those clots do not originate in the lungs, they travel from somewhere else. Diagnosis, again, ultrasound, or they could get angiogram, which is like a CAT scan. They're just like the coronary angiogram. You could get a CT angiogram of your lower extremities. Treatments are going to be anticoagulants. You do need to know your anticoagulants. You need to know about warfarin and what it does. The other option would be an IVC filter. I just want to show you something real quick. I guess I could have went back differently, but the IVC filter, right? When we think about the flow of blood through the heart, the inferior vena cava receives blood from the lower body. An IVC filter is a filter placed in the inferior vena cava to catch any clots in case they do travel before they get to the heart and out into circulation, thus causing heart attack, thus causing PE or stroke. That's what an IVC filter is. Now let me go back to my screen I was on. Sorry, just wanna like to give the visuals. Now, with these patients, you are going to teach them, they do want to elevate the heart elevate the leg once they're on anticoagulants. Elevate the leg, that's fine. They can ambulate once they're on anticoagulation. And of course, teaching them about preventing formation of clots, quit smoking, yada, yada. This is just a picture of how those clots travel. They come up from a DVT in through the heart and get pumped out and get wedged in the blood vessels of the lungs, okay? Now, venous insufficiency. Venous insufficiency results from venous hypertension. So that could be, again, like I said, those people who are in jobs where they're standing all the time, or those people who are just chronic hypertension. Either way, what's happening is blood is going to back up. These people are going to have edema. They're going to have stasis dermatitis from constant swelling, shrinking, blood sitting still. They start to get this thick, dark brown discoloration on the skin, stasis dermatitis. So remember, rubra with peripheral artery disease, brown color discoloration is stasis dermatitis. They're going to have pain. Their legs are going to feel heavy. They're full of water. These people, we want them to elevate the legs above the level of the heart. We want to encourage compression stockings. Peripheral artery disease, we want them to wear loose clothing, because we don't want to restrict blood flow anymore. Whereas vast venous insufficiency, those tight compression hose, just like SCDs, will promote blood flow back up to the heart. And then again, venous stasis ulcers are going to occur usually up around here, the ankle. And that's it. This I didn't mean to throw in there. That's goes with neuro. So that is literally all I have for you as far as lecture and lecturing on cardiovascular. Does anyone have any questions about the cardiovascular system right now? Anybody?
Can you just explain real quick the preload and afterload thing that you said earlier?
Yeah, so preload is the degree that the heart has to stretch. So preload is going to be increased when my volume is increased, right? So hypervolemia is going to cause the heart to need to stretch more, right? Afterload is the amount of force I'm going to need to push all that fluid out, right? Afterload is the amount of force to cause that contraction. So things that increase afterload are things that increase systemic vascular resistance, the amount of force my heart has to pump against. So for preload, really diuretics decrease preload by decreasing the volume. Anything that decreases volume is going to decrease preload. Anything that causes vasodilation is when the blood vessels are opening up and accommodating that extra fluid. Opening up is going to also decrease preload. And then afterload, many of your blood pressure meds, your vasodilators also decrease the force the heart has to pump against. Does that make sense? After lunch, we're going to do practice questions and things on these same topics. So I'm going to keep talking about them after lunch, but now we're going to be more interactive. Did that help, Melissa?
It did. Thank you.
Okay. Anybody else have a question? Wonderful. So with that said, let's go to lunch till 1:15. Is everyone good with that?
Yes.
Yes.
Wonderful. Wonderful. 1:15. I will see you guys back here, and we're gonna go through practice questions, do some Kahoot and other stuff like that to help get the cardiovascular stuff to stick. I will see you guys at 1:15. And actually, just so you guys know, whoever's still here, I'm gonna end this meeting only so the recording can hurry up and download. And then I'll open the meeting back up after lunch, okay? So just log back in at 1:15 because I want to be able to post the recording.
Okay, thank you.
It's the same link.
Yeah, same link. I'm just, if I stop the meeting, then the recording will start processing.
Okay.
All right.